Serge, thanks for inviting me, and thanks for organizing this meeting. So this talk will hopefully complement what Rajit Rampal talked about this morning. And so I'm not going to spend a lot of time on the genetics aspect of this and try to focus more on the clinical aspect, which I think is important. So what is the definition of myelofibrosis, or MPN in blast phase? And this is the formal definition that I'm going to use throughout the presentation, either PMF or post-PVET MF, or MPN in blast phase, which basically means, to me, in this talk, accelerated phase, 10 to 19% blast either in the peripheral blood or the bone marrow, and blast phase disease, 20% blast either in the peripheral blood or bone marrow, with a pre-existing MPN that's documented. So that's going to be the definition for this talk. What are the risk factors? So the risk factors we have listed here are broken down by disease type. So essential thrombocythemia, anemia, and extreme thrombocytosis have been noted risk factors in retrospective analysis. In PV, advanced age, prior exposure to P32, busulfan, pipobromin. I notice that hydroxyurea is not listed there because in a prospective study it's never been shown to actually be definitively associated with increased risk of leukemic transformation. In MF, there's a number of studies that have looked at this over a number of different groups, and you'll see some commonalities. So increase in white count, abnormal karyotype, increase in circulating peripheral blood blasts, thrombocytopenia, anemia. These can all be found in various studies to be significantly correlated with risk of leukemic transformation. So what is the risk? I mean, generally speaking, the risk is lowest in ET, 1%, a little higher in PV, 4%, and 20% over 10 years in MF. This is a slide, I don't know if it comes out well, but this is a slide from Dr. Teferi's publication in Blood in 2014, comparing transformation rates to acute leukemia in ET down below in red, PV in green, and MF in blue of 4, 7, and 14% over a 20-year period. I'm not going to spend a lot of time going over this because this has been done previously and is not really the focus of my talk, but Dr. Teferi and others have looked at how mutation or specifically driver mutation status affects leukemic transformation rates. So one of the things that's been talked about previously at a number of different talks given today is the fact that calreticulin mutation is a good prognostic marker and predicts for a better leukemia-free survival. And in this analysis, compared to triple negativity, which means the lack of any of the driver mutations, 6.5% risk of leukemic transformation in the CALR group versus 25% in the triple negative group. So clearly this molecular profiling can also give one a sense of inherent risk of leukemic transformation. Of course, that does nothing for someone who has calreticulin gene, who you're telling them at their office visit, oh, this is a great prognostic marker, and their blast count is 10%. Cumulative incidence of leukemic transformation of PMF. Again, this is another cut of the pie by Italian colleagues, which again shows that there's an increased risk of leukemic transformation in the triple negative population compared to the calreticulin population. Moving on. So outcome and survival. So this was a study done by the MD Anderson group looking at risk factors. Their goal of this study was to look at retrospectively, find risk factors in patients that predicted a poor survival, less than 1 year. And they came up in a multivariate analysis with blasts in the bone marrow of 10% or greater, abnormal chromosome 17, or thrombocytopenia. So if you had one of those risk factors or multiple, that predicted a poor outcome at baseline, but also in a dynamic fashion, so that the acquisition of any one of these risk factors also increase your rate or risk of leukemic transformation and subsequently poor survival less than a year. Probably more importantly, and reason why I show this slide, is that if you remained in chronic phase, meaning that you didn't acquire any of these features, the overall risk of developing leukemia was quite low, 3% over a 10-year period, whereas it was a continuous risk of progression to AML in patients who acquired these risk factors or acquired the accelerated phase state that they defined within this retrospective study. This was probably one of the first and important publications looking at how poorly patients with MPN blast phase actually do. So this is a retrospective study of 91 patients from Mayo Clinic that Ruben published, and it shows you that the median survival is quite dismal, less than 3 months in the overall population. Sort of the sad part is that if you look at the patients who are treated versus the patients who get supportive care, there's really no significant or appreciable difference in their median survivals. And the same is true in D with induction chemotherapy, which is routinely used for de novo AML, which has better results. You don't get an improvement in outcome truly with induction chemotherapy. And in this publication, I don't actually think that there were any patients that actually achieved a complete remission by IWG criteria. The MD Anderson group also did something similar where they looked at, I think it was 75 patients in this retrospective review of patients treated at their institution for MPN blast phase, and they identified a number of patients, I think 8 in total, that got transplant either upfront or in CR after induction chemotherapy, and then patients who got induction chemotherapy alone, or got low-intensity therapy, which was defined as decitabine, azacitidine, low-dose Ara-C, or supportive care, so transfusions, et cetera. And what you can see is the patients who got transplant, albeit these are low numbers, did well, much better than the other patients who were not given a more aggressive therapy. So at a median follow-up of 3 years, the overall survival was 75% in the transplant arm. And then you can see that the patients who got supportive care did rather poorly, 4 months median survival. And then there was some intermingling between the patients who got induction chemotherapy and low-intensity therapy. And I think that's an important point, which will keep coming up, is that there's really no significant advantage to inducing someone in this disease type unless you're going to consolidate them with transplant. The overall survival doesn't really change in an appreciable way. On the right, you can see the point that if you induce someone with MPN blast phase and you obtain a complete response or a complete response with incomplete platelet recovery versus not, there's really no difference in outcome. And that's sort of a pathetic, sad fact about treating patients in this state of MPN. So this is a great publication by Vikas Gupta's group, where they took 75 patients in their retrospective analysis that go through a treatment algorithm at Princess Margaret Hospital in Toronto. And basically, it's an algorithm up front. You determine whether you're going to go for curative intent or non-curative intent. So obviously, the patients who go for curative intent tend to be the younger patients, fitter, less competing comorbid conditions, and have a transplant, a donor option. So in this analysis, 38 out of the 75, so almost half, went for induction chemotherapy, that followed by transplant if they were in a CR or CRI or had chronic phase MPN features. So a total of 17 went to transplant from this curative intent group, whereas in the non-curative intent group, 37, so about 50%, either got low-dose Ara-C or hypomethylating agent, et cetera, and 2 patients attained a complete response. 1 patient, in fact, went to transplant. What you can see on the A part of this figure is that the median survival for the whole group, curative and non-curative, was approximately 6.5 months. But there was a difference in survival between the patients that had a curative intent versus non-curative intent of approximately 10 months versus 2 months, so there was an improvement in outcome in those patients. And then if you look at part B, patients who were transplanted versus patients who had a complete response with induction chemotherapy but didn't go to transplant, again, it makes the point that there's a significant difference in outcome here. So inducing someone to induce them doesn't really improve their outcome unless it's consolidated by chemotherapy. And if you look at part D, which is patients who attained a complete response or were left with chronic phase MPN features, didn't go to transplant, versus patients who got low-intensity therapy, perhaps decitabine, again, there was no real difference here, which would make you question giving induction chemotherapy unless you had that transplant option to follow. This is from the European Group for Blood and Bone Marrow Transplantation, where they found in their registry of patients with MPNs a total of 46 patients that got transplanted for MPN blast phase. In this group, the median survival, I think, at 2 years was 33%, and the progression-free survival was 26%. But the point that I think is worth mentioning is that if you look at Part B, the only determinant of good outcome in this retrospective review was being in a complete response at the time of transplant. So achieving a response and reduction in blast count before you go to transplant will predict your outcome with transplant as well. Response assessment. So one of the challenges in assessing response, particularly in a clinical trial setting, is how do you define a response in a disease where there's two competing issues. You have an acute phase disease and you have a chronic phase disease that are occurring simultaneously. How does one define that? So a number of years ago, we set out to try to define this for the purposes of creating uniformity in clinical trial testing. And we found that challenging, but we proposed that there were 5 different clinical features that would be important to consider: hematologic profile, reduction in splenomegaly, reduction in blasts and MPN features, and marrow fibrosis, and restoration of normal karyotype, and resolution of molecular markers that could be present. We came up with 6 categories in this consensus modified Adelphi system that we thought would be potentially clinically valuable to use as response criteria that we're planning to validate in ongoing trials. And that's complete molecular remission, which basically means you eradicate any evidence at the molecular level of the leukemia and the chronic phase MPN. And then complete cytogenetic remission, which means that you still have residual molecular markers of the disease. Acute leukemia response means that there's no longer leukemic blast present, but there can still be features of the MPN, and then partial response is obvious, stable disease and progressive disease. So this was an attempt to sort of be able to gauge whether the therapies we're going to be evaluating in clinical trials actually have clinical efficacy. Because right now, IWG-AML criteria is what's being used, but doesn't sort of tell the whole picture because you have an underlying MPN sitting there. Therapeutic approach. So DNMT1 inhibition will be the first part of this area. So I chose this slide, but you could talk about CXCR4, SOX1 and SOX3. But this is a paper by Jen Wang and his group in Brooklyn, where they looked at hypermethylation at P15 and P16, which are negative regulators of CDK4 and 6. What he found in a population of 32 patients that he looked at, 10 of which had MPN blast phase, was that there was hypermethylation at those 2 gene sites, or both of them, exclusively in the MPN blast phase patients, not in the chronic phase patients. This gave us some rationale to use hypomethylating agents in this disease type. So the French group had already looked at their experience within the large registry of AZA-treated patients, 54 in total, that had either MPN blast phase or MPN-related MDS, as shown here. The overall response rate in this subgroup of patients was about 52%. The median cycles to response was approximately 60, and the median duration of response was about 9 months. The overall survival for this group of MPN blast phase and MDS patients was approximately 11 months. 8 months in the blast phase disease patients and 13 months in the MDS cohort. We published in 2010 our experience of 11 patients treated at Mount Sinai. It was sort of a small population now. It's actually much bigger, and we will update it. And we have mature follow-up on this. But these were a number of patients that were treated either with decitabine or transplant if they were eligible, younger, and fit and had a transplant option. And as you can see, the median overall survival had not yet been reached at 9 months at the time of this publication. We have a number of patients now that have been out multiple years, in some cases transfusion independent, reduction in splenomegaly, and leading a good quality of life on decitabine. This was just published, I think, like last month in Leukemia Research. This is from Serge's group, looking at, again, decitabine. This is 20 milligrams per meter squared 5 days in a row, cycled every 28 days, in patients with more advanced disease, so high risk by DIPS or acute accelerated phase or blast phase, as shown here. But I'm going to concentrate on the blast phase patients, the 21 that are shown on the right, where the overall response rate with decitabine, single-agent decitabine, is 29%. This was median cycles to response was 2, median duration of response was 7, and median overall survival in this subgroup was 7 months. Here are the Kaplan-Meier survival curves of the patients that were in MPN blast phase from this analysis. And what you can see in Part B is that there was a statistically significant difference in survival in patients who responded to decitabine versus patients who didn't respond to decitabine, in 10.5 months versus 3.5 months. JAK inhibition, how does this fit in? And we've talked a lot about JAK inhibition in patients with chronic phase disease. Well, Serge's group did a study that was published in 2012 looking at single-agent ruxolitinib at 25 milligrams that could be dose escalated to 50 milligrams in 38 patients that had relapsing refractory AML. Within this cohort of patients, there were 18 that had MPN blast phase, and a third of these patients, of the whole population, were JAK2 V617F positive. In the study, it was well-tolerated drug. There were infrequent grade 3 or 4 toxicities leading to study discontinuation. And there were a total of 3 complete responses, or 2 CRs and 1 CRI. So they also looked at the mechanism of action. And one of the things that they showed here was that in a number of patients that they have graphed here, is there was increased levels of phosphorylated STAT3, and this could be reduced, and this was shown to be reduced after treatment with ruxolitinib. Again, 25 milligrams twice daily. But there was no real change in allele burden. So even in the patients who responded, and 2 of these patients in this JAK2 V617F positive group had CRs, none of them had real changes in their JAK2 allele burden in this study. This is the characteristics of the 3 responding patients. And I just show this to make the point that these were patients who received prior therapy, and patient number 1 had decitabine, and there were reductions in blast percentages, as well as reductions in spleen that were seen. So very recently, the same group, led by Serge at MD Anderson, published their more recent study of phase 1/2 study of single-agent Rux. Now it's super high doses. We're talking 50 milligrams twice daily, 100 milligrams twice daily, and 200 milligrams twice daily. Unheard of. So 27 patients in total were treated. 16 had either prior MPN or MDS. The majority were heavily pretreated, and the median follow-up was 27 weeks. Now, of course, there was an increased risk of and complication as it relates to infection, which is not that surprising given the patient population and the treatment being given. There was 1 complete response with partial count recovery in a patient who had MDS-related AML, who achieved it after 2 cycles but only maintained it for 1 cycle. So combination therapy, which is where a lot of this is going in chronic phase and blast phase disease. Rajit showed this to you earlier. For those of you who didn't catch it, I'll just briefly go over again. So Rajit and Ross Levine at Sloan have created a murine model of MPN blast phase using bone marrow cells from a p53 knockout mouse, transducing them with JAK2 V617F, and then transplanting them in a lethally irradiated mouse. Provides a mouse that looks like AML in many respects, has a high white count, high platelet count, extramedullary hematopoiesis, and tons of blasts, and they don't live very long. If you take those bone marrow cells out and you serially replate them in methylcellulose, you can serially replate them in methylcellulose, thereby credentialing their leukemic phenotype. If you then take those cells and expose them to increasing doses of single-agent ruxolitinib or single-agent decitabine, you get reduction in colony formation that's shown here in a dose-dependent fashion. And it's most pronounced when the 2 are in combination, as shown in the lower figure. This sort of provides us the preclinical rationale for the MPDRC 109, which is a combination study of Rux and decitabine in patients with accelerated phase and blast phase disease, which we're running through the MPDRC. We're on the verge of completing the phase 1 portion and then moving to phase 2. The study is Rux at doses of 10 BID, 15 BID, 25, and 50. And decitabine is 20 milligrams per meter squared, 5 days in a row, every 4 weeks. This is the key eligibility criteria. So again, this is for patients with accelerated phase and blast phase disease, as I've defined previously, and have to have a performance status that's better than 2 and adequate organ function. Like Serge's study of AZA and Rux, we also ease the patients into it. So they get a 7-day course of single-agent ruxolitinib before they get the decitabine, and it's concurrent. So you never stop the ruxolitinib, obviously. And the decitabine is cycled every 28 days. And patients who don't have a DLT can continue on study indefinitely or into disease progression. There are a number of exploratory objectives I think are very exciting, many of which Rajit and Ross are doing at Memorial within the consortium. And basically, these are studies looking at mutational profiling or non-mutational events that either may predict response to therapy or give us more insight into the molecular underpinnings of blast phase disease. So this is a summary of what we know from basically retrospective studies that have been published to date. And what you can appreciate right away when you look at this is that the numbers are all low. except perhaps in Vikas' study, which I think is dead on. And those patients who are fortunate to have to not be old and not be very sick and have a donor, the potential for good outcome is there, 47-month median survival in that group. But otherwise, in the other therapies, it's quite low. I think there's a hint of improved survival in patients who get hypomethylating agents. I think we can say safely that inducing someone without consolidation with a transplant is not going to really get them that far, and that's unfortunate. So to conclude, improving understanding of the genetic and epigenetic events leading to leukemic transformation will continue to guide further clinical trial design. DNMT1 inhibition is an active therapeutic agent for patients with advanced phase disease. I'm excited about the combination trial of decitabine and ruxolitinib and hope to present that soon. Transplant can offer potential for cure for some patients, likely while in complete response or complete remission after induction chemotherapy or decitabine. And MPN blastase remains an unmet clinical need, and patients really should be enrolled in clinical trials whenever possible. And I really try to make that a point to try to put these patients on trial so we can better understand how to treat them, because treating them singly in the community doesn't really get us anywhere. So with that, I'll conclude and thank everyone for listening.